So moving on to pathophysiology, and I think the pathophysiology of cardiovascular disease and HIV might explain some of the variability in results that we find. So this is going to be a little bit of a busy slide, but I'll ask you to bear with me while we work through it. First, I want to concentrate on just the effect of HIV. So we've got someone with HIV infection, and we're trying to figure out what factors might contribute to increased cardiovascular risk in this patient. We know that the virus itself increases microbial translocation across the gut. And we know that microbial translocation has a large effect on immune activation. And it also increases vascular inflammation directly. But because it revs up immune activation to a great degree, immune activation itself then also leads to increased vascular inflammation. HIV, having any chronic viral infection, and we know this is true for HIV, leads to a chronic state of heightened immune activation. And that contributes to vascular inflammation. In addition, before we had antiretroviral therapies, we noticed that people with HIV had lower levels of HDL cholesterol. And we know that HDL cholesterol has an anti-inflammatory effect and is protective against development of atherosclerosis by suppressing TNF-alpha, VCAM1, and other inflammatory cytokines and chemokines associated with endothelial dysfunction and atherosclerotic plaque formation. And having a low level of HDL impairs that anti-inflammatory activity and is associated with more vascular inflammation. So we've got HIV contributing to microbial translocation, immune activation, low HDL, all contributing to increased vascular inflammation, which is associated with endothelial dysfunction and atherosclerosis. Now we add antiretrovirals into the picture. And the antiretrovirals decrease the viral load. We think decreases microbial translocation and immune activation to some degree, but it does not return it to normal levels. So it does not abolish this, it just makes it less. In addition, the antiretrovirals themselves have an effect on visceral adipose tissue, increasing visceral adipose tissue, and we know that adipose tissue is not metabolically or immunologically inactive. In fact, it is very immunologically active, and many adipokines contribute to increased vascular inflammation. In addition, several of the antiretrovirals, some of which we don't use as much now, but some of which are still in use in many countries, such as indinavir and lopinavir, can increase insulin resistance and increase levels of triglycerides and LDL cholesterol, and those contribute to endothelial dysfunction and atherosclerosis. In addition, HIV does not occur in a test tube. These are people who are infected, and patients have their own background risk of atherosclerosis. And there we get the effect of people's hypertension, smoking, their family history, physical inactivity, all of the factors that contribute to atherosclerosis in people without HIV infection are also present and contributing in people who have HIV infection. And the downstream effect of all of this is endothelial dysfunction and atherosclerotic plaque formation. And here you see depicted a vessel with plaque on the upper aspect of the vessel wall. So the impact of HIV and cardiovascular disease is multifactorial. And this is something that we have to think about when we think about how we're studying atherosclerosis in people with HIV and how we're interpreting results of studies. We know that HIV has a direct effect on the vascular wall smooth muscle cells. We spoke about chronic immune activation, inflammation, and monocyte activation. HIV itself also has a direct effect on the endothelium. Several HIV-related viral proteins act on the endothelium, including GP120 that induces T-cell adhesion, NEF that inhibits cholesterol efflux from macrophages and contributes to macrophage activation and foamy cell formation, and TAT inducing secretion of MCP1, CCL2, and stimulating monocyte chemotaxis. And we spoke earlier about some of the antiretroviral medications. To focus just for a minute on monocytes and macrophages, we're realizing increasingly that these cells play a big role in vascular inflammation in people with HIV. The monocytes are recruited from the peripheral blood into the intima of the vessel wall in response to inflammatory stimuli, including cytokines and chemokines. They become tissue macrophages. They absorb modified cholesterol, forming these lipid-laden foam cells that we know are involved in atherosclerotic plaque formation. And the tissue macrophages also produce cytokines and chemokines locally. So once they're in there, they're part of the foamy cells. They continue to produce these cytokines and chemokines that recruit more and more monocytes into the vessel wall. In this slide, I'm not going to go through in great detail because it would take all of the hour, but it just shows the role of some inflammatory markers in atherosclerosis. We know that the inflammation associated with HIV is a major contributor to atherosclerotic plaque formation in people living with HIV. And here, this just shows the carotid artery. This is the common carotid artery. This is where we often measure carotid intima media thickness. And this is a depiction of plaque formation on the inside of the vessel wall, with the foam cells, which are lipid-laden macrophages, and highlighting some of the inflammatory markers that we know are increased in people with HIV, including IL-6 and C-reactive protein. As well, when we look at neovascularization within the plaque wall, CD146, when we look at plaque inflammation and kind of growth of the plaque, some of the matrix metalloproteinases like MMP9, which is elevated in people with HIV, contribute to inflammation within the plaque. When we look at plaque instability and things that lead to risk of plaque rupture, which oftentimes is what precedes an atherosclerotic event like myocardial infarction, we see again CRP, matrix metalloproteinases, IL-6 contributing to plaque instability, and TNF-alpha and neopterin, which are elevated in people with HIV, contributing to severity of stenosis. And a study in Botswana that was published earlier this year looked at carotid IMT and one of the monocyte activation markers, soluble CD163. And CD163 is a marker that sits on the monocyte membrane and is knocked off when the monocyte is activated. So soluble CD163 in the blood is a measure of immune activation or monocyte activation. And in this study, they looked at carotid IMT by HIV status. It was a study conducted in Gaborone in Botswana. And they had 208 HIV infected participants. 55% of them were women, which is something we're often not able to study in the US as well, as a large percentage of women. The mean age was 39, and they were all virally suppressed, and they compared them to 224 HIV negative controls. They found that they did not have any difference between HIV infected and uninfected in carotid IMT. You see that the median carotid IMT was approximately equal in this study, with a p-value of 0.37. However, when they looked at the marker of monocyte activations, soluble CD163, they saw that the HIV-infected participants had significantly higher levels of soluble CD163. It was about 1,917 nanograms per ml, compared with the uninfected controls who had lower levels, 1,593, with a p of 0.003. So in this study, they did not see differences in carotid IMT, but they did see differences in monocyte activation. And with a mean age of about 39 and a small sample size, it is possible that they could not find differences in IMT because these people had so little atherosclerosis at a young age, and they were a relatively small N. And that if they follow these folks for a longer time, and if they had a larger N, they might have seen such differences. But they did see differences in the inflammatory marker. We've had several studies done in the AIDS clinical trial group that looked at endothelial function during antiretrovirals use. And one of those studies, ACTG 5152S, was a sub-study that looked at endothelial function among ARV-naive, HIV-infected patients who were randomized to treatment with 3 different antiretroviral regimens. And what they found that actually after antiretroviral initiation, there was a rapid improvement in FMD, which is a measure of endothelial function, flow-mediated dilation. And that the change in FMD at week 24, so about 6 months after they started, correlated inversely with the change in HIV viral load. So the greater virologic suppression was associated with improved FMD. And there were no differences based on treatment groups. So there was no difference between the people who were on PIs versus NRTIs versus integrase inhibitors. Another study looked at endothelial function among 74 men that were already on antiretroviral therapy for about a median of 5 years. And after adjusting for traditional cardiovascular risk factors, they found that nadir CD4 cell count less than 350 was what was associated with lower FMD, which means poorer endothelial function was associated with having a lower CD4 nadir, but not associated with current CD4 count. Now, there's a group out at Harvard that's looking at arterial inflammation by FDG PET, and they've done some very interesting studies that really allow us to kind of visualize the inflammation in the vessel wall. The first study they did was a relatively small study looking at HIV-infected, a small number of HIV-infected participants, 27, with no history of coronary artery disease who had been on stable antiretrovirals, and 74% of those people had undetectable HIV viral load. And they matched them to controls who had no coronary artery disease, but had the same Framingham risk scores, which is what we were using at that time in 2012 to assess risk for cardiovascular disease. And they also matched them to controls who had known coronary artery disease. So these were men who were HIV infected, no coronary artery disease, controls who also had no coronary artery disease, but similar Framingham risk, and then gender match controls who had known coronary artery disease. What they found is that the HIV-infected patients had a higher scores on their FDG PET scans as measured by TVR than the Framingham risk match controls, and that they had the same amount of uptake, the same amount of inflammation on FDG PET as people who had known coronary artery disease. Now remember, these are people with HIV infection who did not have any coronary artery disease that we were aware of, but their vessels wall was as inflamed as people who had known coronary artery disease. And they found a risk with the same inflammatory marker, the monocyte marker we talked about earlier, soluble CD163, associated with arterial inflammation. And this slide shows the pictures that they got with the PET scan. On the left is the non-HIV Framingham risk match control. And you see this is the ascending aorta. The heart always lights up because it's metabolically active, but the aorta, not a whole lot of uptake. If you look at the participant with HIV, a 42-year-old man, and there's all this uptake in the aorta corresponding to the axial view. And comparing this inflammation to the Framingham risk score matched HIV uninfected participant, you see that the infected participant had a much higher uptake, indicating greater levels of inflammation in the aorta. Now, they subsequently repeated a similar type of study, but they did this in a small number of people who were HIV infected but had not started antiretroviral treatment yet. They were started on elvitegravir, cobicistat, TEF, and FTC, otherwise known as Stribild. And they had FDG PET and coronary CTs at baseline and at 6 months. We don't have the later data. These are the 6-month data that were published at the end of 2016. And viral load was undetectable in 11 of these 12 people after 6 months of antiretrovirals. They had decreased immune activation, but they still continued to have high aortic inflammation with increased FDG PET uptake in the aorta. Even though after treatment, there was decreased uptake in the axillary lymph nodes. So it looks like they had decreased inflammation overall, using the lymph node as a representative of that, but in the aorta itself, they still had increased inflammation. And the next slide here shows this is baseline at the top and after treatment for 6 months at the bottom. And you see at baseline, the axillary lymph node over here was bright. So they had a lot of uptake there, denoting a high level of inflammation. After 6 months of treatment, there was no uptake in the lymph node. They started off with a lot of uptake in the aorta, and in fact, at 6 months, that had increased. Now, it is possible that the effect on the aorta just takes longer, and maybe the follow-up data after a year on treatment will show that inflammation in the aorta has decreased. But from these 6-month data, it looks like we might still have increased inflammation in the blood vessels, even when we've decreased inflammation in the rest of the body. So again, you see the lymph nodes, right and left axillary lymph nodes that were hot before treatment, significantly decreased after 6 months in treatment, but in the aorta, there was uptake before and there was actually more uptake at 6 months. And bringing this into the patient, this is a case that was reported in 2011 by Kalyani et al. There was a 36-year-old man who was kind of just living his life, not ill, had no known cardiovascular disease, no risk factors, had a severe head injury, and unfortunately succumbed to his injuries and passed away. He had an autopsy that showed extensive atherosclerosis, and this is his coronary arteries with, as you can see, very little open lumen. And this gentleman was 36 years old. He smoked cigarettes, but had no other cardiovascular risk. So this has real effects for our patients. And this is just drilling down into the autopsy slide. And you see, I don't know if you can see this very well, but these black arrows point to these foamy macrophages that I described in the previous study. And you can see them in the vessel wall on pathology from this patient.